Okay, welcome to the deep dive. Today, we're getting into something really specific, but super important, especially for you and your revision.
That's right. We've got your notes here, the core stuff on a key topic, and we're basically going to unpack it together.
Yeah, turn these points into something, more conversational, high yield, something that'll actually stick.
Think of it as us helping you navigate the essentials. We'll pull out what you absolutely need to know.
Exactly. And our subject is, well, it's nephrotoxicity due to contrast media. You'll often hear it called contrast-induced nephrotoxicity, or just CIN.
Yep, a potential complication with certain imaging agents. Really crucial to understand this one inside out.
So we're diving into the material you've got.
Yeah.
We hit the definition, the why and how it happens, the nuts and bolts, who's most at risk.
How it looks clinically, how it's diagnosed, and really importantly, prevention and management.
And we'll also touch on the aftermath, prognosis, complications. It sounds like a lot, but we'll break it down bit by bit.
Absolutely. The aim isn't just reading points off a page. It's about making the connections, highlighting the critical bits, so you leave with a really solid grasp.
Okay, let's do it, starting right at the beginning. What actually is contrast-induced nephrotoxicity? How do your notes define it?
Well, at its heart, CIN is kidney damage, and it's specifically caused by the contrast agents used in medical imaging.
Like CT scans or angiography.
Exactly, those kinds of procedures. It's kidney trouble, but the trigger is that contrast exposure.
Okay, so a direct link. And the key thing is timing. Right, it's acute.
Yes, that's vital. The notes stress it's an acute decline in kidney function, and there's a specific window within 48 to 72 hours after getting the contrast.
And how do we measure that? How do we know it's happened based on the info here?
The standard measure is serum creatinine. Your notes give a really specific diagnostic point. This is key for revision.
Okay, what is it?
It's a 25% increase in serum creatinine levels, and that increase has to happen within 3 days, that 72-hour window after the contrast.
Got it. So 25% jump in creatinine within 3 days post-contrast. That's the threshold.
That's the number to lock in.
Right. Now we know what it is. Let's talk why. The causes, the pathophysiology, what's going on in the kidney.
So the root cause is the contrast agent itself being toxic, especially the ones with iodine. But it's not just one hit. It's multiple things happening together.
Okay, let's break those down. What's the first major hit?
A big one is renal vasoconstriction. Basically, the contrast makes the blood vessels inside the kidneys tighten up, constrict.
Which means less blood flow.
Exactly. Less blood flow, less oxygen getting to the kidney tissue. That can cause ischemic injury.
So starving the kidney of oxygen. What else?
Then there's direct tubular toxicity. The contrast agents actually damage the cells lining the kidney tubules themselves, the tiny tubes doing the filtering.
Okay, so restricted blood flow and direct damage to the filtering parts. That sounds like a double whammy.
It really is. And the material adds 2 more factors. Oxidative stress, that's like an imbalance causing cell damage and inflammation, which also fuels the injury.
Wow. So it's a cascade. Vasoconstriction, less oxygen, direct cell damage, oxidative stress, inflammation.
Yeah, all piling on to impair the kidney's filtering job.
And the notes also mentioned that some things make the kidneys more vulnerable to this whole process.
Absolutely. Think of it like the kidneys having fewer defenses beforehand. Pre-existing kidney impairment is, well, it's a massive one. If they're already struggling, this is a bigger hit.
Makes sense.
Yeah.
What else lowers the defenses?
Dehydration is critical. It concentrates the contrast agent in the tubules, making that direct toxicity worse. Also, conditions like diabetes and using other drugs that are known to be tough on the kidney's nephrotoxic meds.
Right. If the kidney's already stressed, it's less likely to cope with this multi-pronged attack, really.
Exactly.
Which leads us straight to, who's most likely to get CIN? Who are the high-risk individuals?
The material lists several key risk factors to know. Like we just said, pre-existing kidney disease is probably the biggest predictor. Even mild issues put someone at much higher risk.
Okay, pre-existing kidney disease is number 1. What else?
Advanced age is a factor. Kidney function tends to decline naturally. Diabetes is a big one. Congestive heart failure, too.
Right.
And hypovolemia, basically being dehydrated or having low blood volume.
Why is dehydration such a risk again?
Well, the contrast isn't diluted as much, and the kidneys just don't have enough fluid to flush it through effectively.
Gotcha. And medications. You mentioned nephrotoxic meds.
Yes, the notes specifically call out NSAIDs, things like ibuprofen and diuretics. They can sort of compound the risk, maybe by affecting kidney blood flow themselves.
Okay. And besides the patient's health, do the actual procedures carry different risks?
They do. Generally, procedures needing more contrast or where it's injected right into an artery carry a higher risk. The notes highlight CT with contrast, and particularly coronary angiography and PCI.
PCI. Percutaneous coronary intervention.
Yeah, those heart procedures where contrast goes straight into the coronary arteries, they seem to have a higher rate of CIN.
And wasn't there a specific stat for PCI in the notes?
There was, yeah. It mentions about 5% of patients having PCI get a temporary increase in their creatinine, defined as over 88 GONs.
5%. That's not insignificant.
No, it really underscores the risk with those specific procedures. It's another key number, like the 25% diagnostic threshold.
Okay, 5% in PCI. So, stepping back, how common is CIN overall? What's the epidemiology look like?
The material notes that getting exact UK-wide data can be tricky, but we do have estimates.
And what are they roughly?
In the general population, people without major risks, it's fairly low, maybe 2 to 5%. But, and this is crucial, it shoots way up in patients with those risk factors.
Like pre-existing kidney disease or diabetes.
Exactly. If you've got chronic kidney disease and diabetes, your risk is significantly higher than that baseline 2-5%.
Okay, so rare in healthy folks, but a big worry for vulnerable patients. Now, how does it actually look? What are the clinical signs?
Well, it can vary. But the defining thing, as we said, is that jump in creatinine on the blood test. You don't see that directly on the patient, obviously.
Right, that's the lab result.
Yeah.
But what might you observe clinically?
You look for signs the kidneys aren't doing their job properly. Decreased urine output is common. They're not filtering as well.
Which could lead to fluid buildup.
Yep, fluid retention, maybe swelling, edema, in the legs or face. Electrolyte imbalances can happen too because the kidneys regulate things like sodium, potassium.
So basically, it looks like an acute kidney injury, an AKI.
Precisely. The signs are classic AKI. Swelling, tiredness, maybe even confusion if waste products build up.
And the really severe cases.
The material mentions severe cases might lead to oliguria, that's very little urine output, or even anuria, like basically no urine at all. Those are signs of serious kidney failure.
Okay, that paints a clear picture. How do clinicians nail the diagnosis? What investigations are key?
It's really a mix of clinical assessment, looking at risk factors, symptoms, the timing with the contrast, and lab tests.
And I'm guessing creatinine monitoring is front and center.
Absolutely central. The standard practice, stressed in the notes, is measuring creatinine before the contrast and then again after to spot that rise within the 3-day window.
That before and after comparison is how you confirm it, using that 25% rule.
That's exactly how you do it.
Any other tests mentioned?
Urine analysis is mentioned. It can give clues about kidney damage, looking for things like protein or cells in the urine.
What about more scans? Would you do another CT to diagnose CIN?
Generally, no, not to diagnose CIN itself after it's suspected. Imaging might be used beforehand, though.
Beforehand? For what?
To check the kidney structure, rule out other causes of kidney problems, or even help decide if contrast is safe or necessary in the first place, especially if someone's high risk. It's more about risk assessment before, not confirming CIN after.
Okay, so mainly it's those pre- and post-contrast creatinine levels. Got it. Let's switch to what we can do. Management and maybe more importantly, prevention. What works?
Yeah, management is heavily focused on prevention first,
Yeah.
and then supportive care if CIN does happen. And the good news is there are definite steps to lower the risk beforehand.
What's the absolute cornerstone of prevention?
Hydration. Proper hydration is crucial. It helps dilute the contrast and keeps good blood flow going to the kidneys.
And the notes get specific here, right? This sounds like high-yield stuff.
Very specific. Intravenous 0.9% sodium chloride normal saline is recommended, and the rate and timing are key. 1 mmol per kilogram per hour. Start it 12 hours before the procedure and keep it going for 12 hours after.
Wow, okay. 5E normal saline.
Yeah.
1 LLK hour, 12 hours before, 12 hours after. That's a recipe to remember.
Definitely. The material also mentions isotonic sodium bicarbonate as another option, and choosing the type of contrast matters too. Low osmolar or isoosmolar agents are generally preferred as they're less toxic.
I think I saw something in the notes about a treatment that doesn't work anymore.
Yes, that's important too. Shows how things change. N-acetylcysteine, or NAC. It used to be given sometimes, but the notes point out recent studies show it's actually ineffective for preventing CIN.
Good to know what not to rely on.
Yeah.
What about high-risk folks, especially those taking metformin?
Ah, yes, critical point for patients with diabetes. Metformin can build up if kidney function drops suddenly, leading to lactic acidosis, which is dangerous.
So what's the guidance?
Clear guidance in the notes. Hold the metformin for at least 48 hours, 2 full days after the contrast, and don't restart it until you've checked their kidney function and confirmed it's back to normal.
Hold metformin for 48 hours post-contrast. Check labs before restarting. Vital safety step.
Absolutely vital.
So, okay, you've done the prevention, but CIN still happens sometimes. What's the supportive care then?
Then the focus is on supporting the kidneys while they hopefully recover. Maintain hydration carefully to avoid fluid overload if they're not making urine. Keep a close eye on kidney function with more blood tests. Manage any electrolyte problems.
Just trying to keep things stable to give the kidneys a chance.
Pretty much. And in those severe cases we mentioned, with little or no urine,
Then what?
then, as the material says, they might need renal replacement therapy. Temporary dialysis, basically, to do the kidney's job until they recover.
Okay, that covers prevention and management. What about the outlook? Prognosis after CIN and potential complications.
Generally, the prognosis is actually quite good. In most cases, the kidney damage from CIN is reversible. Function usually gets back to baseline within days to weeks. That's a key positive point.
That's reassuring. But recovery can take longer sometimes.
Yes, definitely. The notes say prolonged recovery is a risk, especially for patients who already had kidney disease or multiple risk factors. Their kidneys just have less reserve to bounce back.
So spotting it early and managing it well really matters for the outcome.
Huge difference. Early recognition, prompt supportive care, it all helps improve the chances of a full recovery.
What complications could happen, though?
Well, the initial injury could worsen before it gets better. There's a risk of prolonged kidney dysfunction function not quite returning to normal. Significant fluid and electrolyte issues can arise.
And the most serious long-term possibility mentioned.
The potential development or worsening of chronic kidney disease, CKD, especially if the CIN was severe or happened multiple times or in someone already vulnerable. And like we said, severe cases might need dialysis temporarily, which is a major intervention.
So, although it's often temporary, CIN isn't trivial. It carries real risks, especially for vulnerable patients, maybe even long-term kidney damage.
That's the bottom line. It really drives home why careful risk assessment, prevention, and close monitoring are so important. It's about stopping CIN if possible, but also minimizing harm if it does occur.
This has been incredibly useful, really digging into the material you provided on CIN. We've walked through the definition, how it happens, the risks, presentation, diagnosis, prevention, management, and the outcomes.
Yeah, we tried to extract the really high-yield stuff from your notes, hopefully connecting the dots in a way that makes it easier to remember for your revision.
Absolutely. Understanding these points is just fundamental. And thinking about all that, the risk factors, the specific preventative steps like hydration, the potential outcomes. Here's something to maybe mull over. Considering all those factors, what single element in that whole pathway assessment, prevention, management, do you think is the absolute most critical leverage point for preventing severe CIN? Is it identifying the risk early, that hydration protocol, something else?
That's a great question. Really makes you think about the practical application, where the biggest impact lies.
Well, that brings our deep dive on contrast-induced nephrotoxicity to a close. We really hope breaking down your vision notes like this has helped clarify things for your studies.
Yeah, mastering these concepts is definitely key.
And remember, all this info, plus tons more great revision material, can be found elsewhere.
That's right. For loads more resources, definitely check out passthemsra.com.
And also freemitra.com. Both are packed with useful stuff for your studies.
Well worth a look.
Go check them out. And to you, thanks for joining us on this deep dive through your notes. Keep up the great work with the revision.